You wake up, walk to the bathroom mirror, and your face looks different. Puffy around the eyes, swollen along the jaw, a fullness under the cheekbones that was not there when you went to bed. You press your finger against the skin below your eye, and the tissue gives more than it should. You have been dismissing this for months, maybe years. You call it sleep lines. You call it lying wrong on the pillow. You call it getting older. You drink your coffee, go about your morning, and by mid-afternoon the puffiness has mostly resolved. So you stop thinking about it until the next morning when it is there again. What I want to show you today is that the story you have been telling yourself about morning facial puffiness, that it is caused by how you slept, by the pillow, by fluid pooling in the face during the night, is physiologically incomplete. And in a subset of seniors, it is dangerously incomplete. Because morning facial edema, particularly the kind that is present consistently, the kind that involves puffiness around the eyes and along the lower face, the kind that occurs without a clear dietary or allergic explanation, is one of the classical early presentations of reduced kidney filtration capacity. And reduced kidney filtration is a condition that affects an estimated 37 million American adults, that has no symptoms in its early and middle stages beyond precisely the signs that most seniors are attributing to sleep, and that progresses silently and irreversibly if the signals are not recognized and acted on. I am Dr. Edward. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. Morning facial puffiness has multiple potential causes, and most of them are benign. This video is not intended to alarm you, but to ensure you have the information to recognize which pattern of puffiness warrants medical investigation and which specific tests to request. If you are experiencing facial swelling alongside shortness of breath, chest pain, or significant leg swelling, please seek medical evaluation today rather than watching the rest of this video, and please subscribe to this channel before we continue. I cover the research that closes the gap between symptoms you have been told to accept and the clinical explanations that can change what happens at your next appointment. It is free and it takes 2 seconds. Subscribe and stay with me, because the biology I am going to walk you through genuinely changes how you interpret something you have been looking at in the mirror every morning. Let me start with the physiology of fluid balance in the body, because this is the foundation that makes everything else I am about to say make sense. Your body is approximately 60% water by weight, and that water is distributed across 3 compartments. Inside your cells, in the space between your cells and tissues, called the interstitial space, and within your blood vessels. The distribution of fluid across these compartments is not random. It is continuously regulated by a set of physical and chemical forces. The osmotic pressure exerted by proteins in the blood, particularly albumin, the hydrostatic pressure generated by the heart pumping blood through the vessels, the sodium and water balance maintained by the kidneys, and the lymphatic system that drains excess fluid from the tissues back into circulation. When all of these forces are in equilibrium, the interstitial spaces remain at their appropriate volume. Tissues look and feel normal. Faces do not puff. When any of these regulatory systems fails or is overwhelmed, fluid shifts into the interstitial space and stays there. This accumulation of excess fluid in the tissues is called edema. In the face, where the skin is particularly thin and the connective tissue is relatively loose, especially around the eyes, where there is almost no supporting subcutaneous fat, even small amounts of interstitial fluid accumulation produce visible puffiness that is disproportionate to the actual fluid volume involved. The face is, in this sense, a sensitive barometer for systemic fluid regulation. Small disruptions that would be invisible elsewhere in the body become immediately apparent in the periorbital region. Now let me explain why the kidneys are central to this story, because most people understand the kidneys primarily as organs that make urine, and that functional description, while not wrong, dramatically understates their role in fluid and electrolyte homeostasis. Your kidneys filter approximately 180 liters of blood plasma per day, not 180 milliliters. 180 liters, your entire blood volume filtered and processed roughly 60 times every 24 hours. The filtration unit is the glomerulus, a microscopic cluster of capillaries in the kidney surrounded by a specialized capsule. The glomerular filtration rate, abbreviated as GFR, is the measure of how efficiently this filtration is occurring, and it is the single most important metric of kidney function in clinical medicine. Among the many things the kidneys regulate through this filtration process is sodium balance. Sodium is the primary determinant of extracellular fluid volume, the volume of fluid outside your cells, including the blood and the interstitial fluid. When kidney filtration capacity falls, the kidneys become less efficient at excreting the sodium load from diet. Sodium is retained. Water follows sodium because the body maintains sodium concentration within a narrow range and retains water to do so. The extracellular fluid volume expands. That expanded fluid volume begins to accumulate in the interstitial spaces, particularly in dependent or loose tissue areas. The face, the periorbital region, the ankles. Morning facial puffiness is, in this physiological context, a visible expression of the sodium and water retention that occurs when the kidneys are not filtering efficiently. The reason this puffiness is characteristically worse in the morning and improves through the day relates to posture. When you are lying flat during sleep, the hydrostatic pressure gradient that normally keeps fluid in the lower extremities is equalized across the body. Fluid that would otherwise pool in the legs and feet during the day is redistributed into the face, the periorbital tissues, and the upper body during sleep. In healthy individuals with normal kidney function, this overnight redistribution is modest and resolves quickly once they are upright and the kidneys excrete the excess sodium and water with normal efficiency. In individuals with reduced kidney filtration capacity, the overnight redistribution is greater because total extracellular fluid volume is already expanded, and the resolution is slower or incomplete because the kidneys cannot excrete the excess efficiently. The result is the characteristic pattern, puffiness, present on waking, slow to resolve, recurring every morning, and progressively more pronounced over months as kidney function continues to decline. I want to give you the numbers because I think the scale of undiagnosed kidney disease in the senior population is something that most people have not fully absorbed. According to the National Kidney Foundation, approximately 90% of people with chronic kidney disease do not know they have it, not 10%. 90%. The disease progresses through 5 stages based on GFR, and stages 1 through 3, which together represent the majority of all chronic kidney disease, produce no symptoms that most people would associate with kidney failure. The fatigue is attributed to aging. The mild ankle swelling at the end of the day is attributed to being on your feet. The morning facial puffiness is attributed to the pillow. By the time symptoms are unmistakable, by the time GFR has fallen below 30% of normal function, which is stage 4, the disease has been progressing for years. The kidneys have lost the majority of their reserve, and the treatment options have narrowed considerably. Subscribe to this channel right now if you want to keep receiving research like this, the kind that gives you the clinical context to recognize what your body has been trying to tell you. Tap that subscribe button. It costs nothing, and it changes what happens at your next doctor appointment. Now I want to distinguish between the morning facial puffiness that warrants concern and the morning facial puffiness that does not, because not all puffiness is a kidney signal, and I want to be precise about what distinguishes them. The facial puffiness that is unlikely to reflect reduced kidney filtration is puffiness that resolves completely within 30 to 60 minutes of waking and rising. Puffiness that is clearly linked to a specific trigger, such as a high-sodium meal the evening before, alcohol consumption, a specific food, a new skincare product, or seasonal allergies. Puffiness that is asymmetric, worse on one side, which typically reflects positional fluid pooling or local inflammation rather than systemic fluid dysregulation, and puffiness that is limited to the lips or tongue, which suggests an allergic mechanism rather than a filtration problem. The facial puffiness that warrants medical investigation is puffiness that is present consistently, multiple mornings per week or every morning for a period of weeks to months. Puffiness that takes more than an hour to resolve or that does not fully resolve by midday. Puffiness that is bilateral, affecting both sides of the face symmetrically and concentrated around the eyes and along the lower face. Puffiness that is accompanied by other subtle symptoms, including fatigue, reduced urine output, urine that appears foamy or frothy, mild ankle swelling at the end of the day, or persistent mild itching without an identifiable skin cause, and puffiness that has been gradually worsening over months, even without obvious dietary changes. The foamy urine point deserves specific attention because it is one of the most clinically significant early warning signs of kidney filtration problems and one of the most consistently overlooked. Foam or persistent bubbles in the urine indicate the presence of protein, specifically albumin, in the urine. Healthy kidneys do not allow significant amounts of albumin to pass through the glomerular filter into the urine. When the filter is damaged, albumin leaks through. This is called proteinuria, and it is one of the earliest measurable indicators of glomerular injury, detectable years before GFR falls significantly. If you have noticed that your urine is frothy, not just a few bubbles that disappear immediately, but a persistent foam that lingers, and you also have morning facial puffiness, that combination is a specific clinical pattern that your doctor should investigate with targeted testing today, not at your next annual physical. Now I want to talk about the specific tests that actually identify kidney filtration problems because there is a significant and consequential gap between what the standard annual physical includes and what the kidney filtration research recommends. The standard annual physical panel typically includes a basic metabolic panel or comprehensive metabolic panel, which reports creatinine and an estimated GFR calculated from that creatinine level. This is a reasonable starting point, but it has a critical limitation that most patients are never told about. The estimated GFR calculated from serum creatinine underestimates kidney disease in older adults, particularly in those with low muscle mass. Creatinine is a metabolic byproduct of muscle tissue. Seniors with sarcopenia, the age-related loss of skeletal muscle, produce less creatinine, so their creatinine-based estimated GFR appears artificially normal even when actual filtration is significantly impaired. A study published in the American Journal of Kidney Diseases found that in adults over 65, creatinine-based GFR equations overestimated actual filtration capacity by a clinically meaningful margin in a substantial proportion of subjects. The more sensitive approach for seniors is a combination of three tests: the estimated GFR from creatinine as a baseline, a cystatin C-based GFR calculation, which uses a different kidney filtration marker that is not affected by muscle mass and is more accurate in older adults, and a urine albumin to creatinine ratio, which detects the early proteinuria that indicates glomerular filter damage before GFR falls significantly. Together, these three tests provide a picture of kidney filtration that no single test can give alone. The urine test in particular is important because it can detect filtration problems that the blood tests still show as normal. When you request these tests, and I want you to request them by name at your next appointment, you can use this specific language. I have been experiencing consistent morning facial puffiness, and I would like a cystatin C-based GFR calculation and a urine albumin to creatinine ratio, in addition to my standard metabolic panel. Those words will communicate to your doctor that you understand the limitation of standard creatinine-based GFR in older adults and that you want the more sensitive assessment. Most physicians, presented with a patient who knows the clinical reasoning behind their request, will engage with that request seriously. If your doctor orders only a standard creatinine and you come back with results that are technically normal but at the lower boundary of the normal range, ask specifically, what is my cystatin C-based GFR? Ask for the urine albumin to creatinine ratio. Do not accept a normal creatinine result as complete reassurance when you are symptomatic. The gap between what the standard test catches and what the more sensitive tests reveal is precisely the gap in which early-stage kidney disease lives for years before becoming detectable by conventional means. I also want to address the medications that contribute to reduced kidney filtration in seniors, because this is a clinical reality that affects millions of people who believe their kidneys are being protected when they may in fact be under ongoing pharmacological stress. NSAIDs, nonsteroidal anti-inflammatory drugs including ibuprofen, naproxen, and aspirin at higher doses, are nephrotoxic. They reduce filtration by constricting the afferent arteriole, the blood vessel that supplies the glomerulus, reducing the blood flow and pressure that drives filtration. Short-term use in healthy kidneys is generally recoverable. Chronic daily use in seniors with already reduced GFR, which often includes people with arthritis pain who take NSAIDs as a daily routine, can produce progressive and irreversible filtration loss. The morning puffiness in a senior who takes ibuprofen every day for joint pain, whose kidneys are already filtering at 60% of normal capacity, may be a direct pharmacological consequence of their pain management approach. ACE inhibitors and ARBs, two of the most commonly prescribed blood pressure medication classes, have a complex relationship with kidney function. In patients with diabetic nephropathy and proteinuric kidney disease, they are actually protective. They reduce intraglomerular pressure and slow filtration decline. But in patients with significant renal artery stenosis, or in volume-depleted patients, or in seniors who are also on diuretics and NSAIDs simultaneously, they can precipitously reduce GFR. The triple combination of a diuretic, an ACE inhibitor or ARB, and an NSAID, called the triple whammy in nephrology, is one of the most common causes of acute kidney injury in the senior outpatient population. If you are on all three of these medication types, your kidneys are under a chemical stress that your prescribing physicians may not be jointly aware of, because each of those medications was likely prescribed by a different doctor at a different appointment. The solution is not to stop your medications. It is to bring your complete medication list to every physician appointment, specifically to ask whether your combination of drugs is being monitored for cumulative nephrotoxic effects, and to request kidney function testing more frequently than the standard annual frequency if you are on nephrotoxic drug combinations. I want to share something about a pattern I think is worth naming directly. Many seniors who eventually receive a chronic kidney disease diagnosis will look back and identify a period of months or years during which they had morning facial puffiness, mild fatigue, slightly foamy urine, and occasional ankle swelling, and in which none of their physicians connected those individual dots into a picture of early kidney filtration decline. Each symptom was addressed in isolation or dismissed. The fatigue was attributed to age. The swelling was attributed to the pillow or the heat. The foamy urine was never mentioned because the conversation never happened. The result was a diagnosis that arrived later in the disease course, when treatment options were narrower and the filtration capacity that had been lost was not recoverable. I make this video because information is the only thing that interrupts that pattern. A patient who knows that morning facial puffiness, particularly in the periorbital region, particularly when combined with foamy urine and mild fatigue, is a recognized early signal of kidney filtration decline. That patient will mention it to their doctor. They will ask for the specific tests. They will not accept a normal creatinine as complete reassurance. And that difference in timing, catching reduced filtration at stage 2 rather than stage 4, is the difference between a conversation about lifestyle modification and a conversation about dialysis. Here is the summary of everything we covered. The kidneys filter 180 liters of blood per day and regulate sodium and water balance, which determines extracellular fluid volume. When filtration capacity falls, sodium is retained, fluid volume expands, and excess interstitial fluid accumulates in the loose connective tissue of the face and periorbital region, producing the morning puffiness that is typically attributed to sleep position. 90% of people with chronic kidney disease do not know they have it because early-stage disease produces symptoms that match the accepted narrative of aging. Morning facial puffiness that is bilateral, periorbital, consistent, slow to resolve, and accompanied by foamy urine, mild fatigue, or ankle edema is a clinical pattern that warrants kidney investigation. The standard creatinine-based GFR underestimates filtration decline in seniors with low muscle mass. Request a cystatin C-based GFR and a urine albumin to creatinine ratio by name. NSAIDs taken daily and the triple combination of diuretics plus ACE inhibitors or ARBs plus NSAIDs are common pharmacological contributors to filtration decline that most senior patients are not aware of. If this video gave you something concrete, a test to request, a symptom to report, a medication combination to question, please share it. Share it with the person in your life who has been looking at their puffy morning face for years and calling it a pillow problem. Share it with the adult child whose parent is on multiple blood pressure medications and takes ibuprofen daily and complains of fatigue. This information is specific, it is actionable, and sharing it costs nothing but could change a clinical outcome. Subscribe to this channel if you have not already. My next video covers the other early kidney warning signs that standard annual physicals consistently miss, signs that are present and measurable years before GFR falls into the range that triggers a formal diagnosis. You will want to see that video before your next blood panel. Subscribe so it comes directly to you. I am Dr. Edward. Your kidneys are working every second. Make sure your doctor is checking them the right way. I will see you in the next one.